I really appreciate Alex and its team's effort for this wonderful series of the lectures of ToxMaster for the DABT candidate. So, first of all, I thankful to Alex and its teams. And thank you for providing me a very nice opportunity to deliver the talks in this ToxMaster class series. Once again, I am thankful to Drupal, Hanuman, Alex, and its whole team for the nice organizing such event in a highly effective way. So before initiation of my talk, we need to understand what is the importance of this topic, how it is correlated with our routine. On daily basis, we are continuously contact with the different toxicants. Toxicants are entered through the food we eat, water we drink, air we breathe, and also medications have its own side effects on a toxicology point of view. To depend upon its physical and chemical properties, toxicants absorb in our body. But fortunately, God gave us a very good mechanism in which body has ability to biotransport and excrete that toxicant from our body. Through the EDME mechanism, we can call it as absorption, distribution, metabolism, and excretion. But when there is a disturbance in this EDME process, it develops a different toxicity. Therefore, the proper knowledge and understanding of the disposition of chemical and its grade is much more important to judging the toxicity of toxicant for all our toxicologists. So, my topic is directly correlate with toxicokinetic. In short, we can call it as a TK. A toxicokinetic describes what body does with the drug or the chemical or its metabolites or toxicants. So toxicokinetic principles include absorption, how will it get into the body, distribution, where will it go and transfer to the whole body system, metabolism, in which how is it broken down, and excretion, how does it remove from our body. So toxicokinetic is nothing but the quantitative measurement of EDME of chemicals or toxicants by their concentrations in the biological matrix, such as a blood, plasma excreta, inhaled air, tissue, over a period of time. So Paracelsus stated that all things are poison. Nothing is without poisons. Only the dose make the things are not poisons. So toxicity directly depend on the dose. Here toxicants are exposed to the body through the different route of administration. After entry of the toxicants, it crosses the different barrier where and reach to the site of actions. So the main barrier in our body comprise of the skin, lungs, and gastrointestinal tract through which drugs are absorbed. Once drugs are absorbed, toxicant distribute that drug to various tissue and the organs through the blood circulatory system. For potential actions of the drug, sufficient high concentrations is required at the site of actions to develop its pharmacological effect or toxicity. But sometimes higher concentrations available at the target organ does not reveal any toxicity. Take an example of DDT. It is nothing but the insecticide that achieve the high concentration in the fat depot, but it does not overt any toxicity to this tissue. Some chemical may have a one target organ, some may have a several target organ because of their property and the ADME for that particular chemical. A chemical that is well absorbed but rapidly transported or eliminated from the organism or the body is less likely to be toxic because rapid excretion prevent it from reaching the sufficient high concentration to deliver the potential effect of the drug, maybe pharmacological effect or the adverse effect of the toxicant. Body eliminates the toxicant primarily through the urine, feces, by the exhalation, sweat, saliva, sperm, tears, and many more. So absorption, distribution, and elimination determine the concentrations at the site of action, which leads to favorable effect or the adverse effect of the toxicant. So for the better understanding of the ADE, here's a summary of disposition of chemicals. Here we can see the major pathway of the absorption of toxicants are highlighted in the black colors. So gastrointestinal tract through absorption is reached to the systemic circulation. Through inhalation, it reaches to the systemic circulation. From dermal, through screen, it reaches to the circulations. So from this, along with the other parenteral route, toxicants are entered into the systemic circulation. After reaching to the systemic circulation, toxicant distributed in all the body organs through the circulatory systems. It may be kidney, lungs, extracellular fluid, livers, and many more, which is highlighted by blue line. And finally, the pathway of final excretion or elimination of the toxicant from the body through the feces, urine, and expired air. So, and for the absorption rate of the parenteral route, intravenous, then intraperitoneal, then intramuscular, and lastly, the subcutaneous fluid absorbs more as compared to the oral route. Now, what is absorption? Absorption is the first process of toxicokinetics. It is important for toxicant actions. Without it, there will be no any actions of the drugs. If drug is not absorbed, then there is no any adverse or favorable effect of the drugs. So it is a process transport of toxicant from its site of administration to the systemic circulation passing through the biological membrane. Xenobiotics penetrate the membrane during the absorption by the same process as do biological essential nutrients are reaches to the different cell organs. The GI tract is one of the most important sites where toxicants are absorbed. Sometimes the toxicants are ingested along with the food material and absorbed in the different systems. Some of the doctors also prescribe certain medicines is before meal and after meals. There is also an importance of absorption. Suppose each and every drug have its own characteristics. After oral ingestion, it is disintegrated and dissolution occurs in the stomach. Then absorption is possible. So take an example, omeprazole, ranitidine should be taken before meal and some drugs prescribed after meal. But take care, there should be a sufficient gap in between the meal and the administration of the dose. At least 1 hour gap is required for proper absorption of the drug after meal. Because when drug is ingested along with the food material, the disintegration and dissolution is not proper because of the food material available in the stomach. The different barriers play an important role in absorption. For absorption and distribution, toxicant travel through the multiple cellular barrier, including cell of the skin, cell of the lung, cells of the gastrointestinal tract, cells of the vessels, that is capillary endotheliums. Ultimately, the toxicant reaches to the cells of the target organ, where it produces the favorable or adverse effect. The plasma membrane is also known as cell membrane, is a critical component of each and every cell. So toxicant have to pass this cell membrane, and it acts as a protective barrier and regulating the movement of the substance in and out of the cell. This cell membrane comprised of the lipid bilayer composed primarily of the phospholipid, glycolipid, and cholesterol. And this membrane comprised of the four major phospholipid content: phosphatidylcholine, phosphatidylethanolamine, phosphatidylserine, and sphingomyelin. Here is a schematic diagram of the cell membrane. It is composed of the phospholipid bilayer. This is a molecule of the phospholipid. This is head part and this is the tail part. And these phospholipid are arranged in the two layers. This is first layer and this is second layer. And the thickness of the cell membrane is about 7 to 9 mm. And the specific orientations of this phospholipid, the polar head, this head is facing inward and outward of the membrane, whereas this is the tail part, which is a hydrophobic tail, which are oriented inwards and facing with each other, which create the cell membrane is hydrophobic in nature. So water molecule is not passing through this cell membrane because of these lipid bilayer structures. Cell membrane act as a selective barrier. Each and every particle are not crossing the cell membrane. Some are passing and some are not passing. So it depends and regulates the movement of toxicant based on their physiochemical property. Toxicant passes the barrier by the two mechanisms or the process. First is passive transport process and another is active transport. Passive transport process in which no energy is required, whereas in the active process, energy is required. This is the main difference. The passive transport is divided into two parts: simple diffusion and the filtration. In the simple diffusion, many toxicants cross the membrane by the simple diffusion process following the principle of the Fick's law, which establishes that chemical moves from the region of higher concentration to the lower concentration region without energy. So according to the Fick's law, a less thick wall, small molecular weight, increased concentration gradient, and large surface area enhance the rate of diffusion and allowing the substance to pass through the membrane more efficiently. And rate of diffusion is proportionate to the surface area multiplied by the concentration difference and divided by the thickness of membrane based on these principles. Here we can see this is the cell membrane. The concentrations of the toxicant is more in this side, and with the help of diffusion mechanism, it is passing from outside to the inside, in which small hydrophilic molecules are transferred to the paracellular diffusion mechanism, whereas hydrophobic molecules are transferred through the transcellular diffusion mechanism. The small hydrophilic molecule up to 600 Dalton that permit through the aqueous pores, which is available within the cell membrane. In the simple diffusion, lipid solubility is generally determined by the octanol water partition coefficient P, which is defined as the ratio of concentration of compound in organic and aqueous phase under the equilibrium conditions. So diffusion is directly proportional to the lipid solubility. When any toxicants have a more lipid soluble, then the cell membrane transfer is efficiently more as compared to the water soluble compounds. It is expressed in the log P. Log P is extremely informative physiochemical parameter for lipid solubility. Here is the octanol water partition coefficient in the different molecule expressed in the log P value. This is the log P value, where higher P value, this is higher P value or positive value indicate greater lipophilicity, meaning the compound is more likely cross the lipid membrane. Whereas the lower P value or the negative value, we suggest that it is having the strong affinity for the aqueous environment and it reduces the membrane permeability. Suppose take an example of amino acids such as the glycines, and this type of glycines, glutathione, cysteines is more highly water soluble, and this is the negative log P value and not permeable to the cell membrane. Whereas DDT, TCDD, parathiones have a more positive log P value, are more lipid soluble and easily cross the lipid cell membrane. Based on the degree of the ionizations, molecules are divided into two forms, non-ionized form and the ionized form. Lipophilicity is also a fat-soluble molecule cross the biological membrane more easily through the passive diffusion. They can dissolve in the lipid bilayers. Whereas in the ionized form is nothing but the hydrophilic water-soluble molecule generally require facilitate transport via carrier, certain protein channel is required, or active transport mechanism required to pass the cell membrane. The effect of the pH on the degree of ionizations of organic acids and organic base is illustrated in this figure. Here at low pH, a weak organic acid as a benzoic acid. This is a benzoic acid structures and this is a aniline structures. So at low pH, a weak organic acid such as a benzoic acid is largely non-ionized. And at pH 4, exactly 50% of the benzoic acid is ionized and 50% is non-ionized, because this is the pKa of these compounds. pKa indicate the 50% of ionized and 50% are non-ionized with each and every compounds, which indicate by the term pKa for the acidic and pKb is for basic compounds. As the pH increase, more and more proton are neutralized by the hydroxyl group and benzoic acid continues. More and more proton are neutralized by the hydroxyl group and benzoic acid continue to dissociate until almost all it neutralized the ionized form. It means, suppose this is a benzoic acid, this when it becomes acidic, then more ionization form is there. When it becomes alkaline, then there is a less ionization form. For organelles base, the inverse is true, such as the aniline at low pH when protons are abundant. Sorry. At low pH when protons are abundant, almost all aniline is ionized. As the pH increase, ion form aniline continue to dissociate until this is full ionization occurs in the alkaline media for the aniline. Similarly, for the different compound, the bases and acid have a different pKa value. Suppose chloroquine have a more ionization from at 12 pH, whereas levodopa is more ionized at pKa value of 2. Transmembrane passage is largely restricted to the non-ions form. Benzoic acid is more readily translocated through the membrane from acidic environment, whereas more aniline is transferred from an alkaline environment. And filtration. Filtration is the movement of water and the solute molecule across the cell membrane due to hydrostatic pressure generated by the cardiovascular systems. It is a second passive diffusion process. When water flow in the bulk crosses the porous membrane, any solute small enough to pass the pores of the cell membrane through the filtrations. In renal glomeruli, primary site of filtration, these pores are relatively large, about 70 nanometers, allowing the molecules smaller than the albumin to pass through this. So this is a schematic diagram of the glomerulus, where this is afferent arteriole and this is efferent arteriole. Afferent arteriole take the blood into the glomeruli and efferent is removing the blood from glomeruli. Here is the tuft of capillary network within the glomeruli, and this is the Bowman capsule. Here, the glomerular blood hydrostatic pressures in the afferent arteriole and the capillary is about 30 mmHg, whereas the capsular hydrostatic pressures in the capsule is 15 mmHg. So because of the more pressures of the blood and arrangement of the epithelial layer of the glomerulus, the chances of filtration is more as compared to the other epithelial membrane. Now we switch over to the special transport mechanism. Some compounds are too large to pass through the aqueous pores or too insoluble in lipid to diffuse across the lipid domain. That compound are often transported very rapidly across the membrane, even against the concentration gradient. And these phenomena are understood with the help of special transport systems. These systems are responsible for transport of toxicants, maybe influx or efflux across the cell membrane for many nutrients, as well as certain amino acids, sugar molecules, and sometimes different toxicants. In the special transport mechanism are mainly 4 types: facilitated transport, active transport, xenobite specific transports, and some of the additional transport process. In facilitated transport, apply the carrier-mediated transports. So it requires the different protein-based carrier to transfer the toxicant from one part to the another part of the cell membrane. The transport of the glucose from the GI tract across the basolateral membrane of the intestinal epithelium from placenta into the blood cells and from the blood into the central nervous system occur by the facilitated diffusions via glucose transporter. So facilitated transports is nothing but the protein carrier-mediated transports. And with the two type of transporters, there is a non-specific transporter where any toxicant can pass through that protein carrier. Sometimes there is a specific transporter. Here, this is a glucose transporter. And it is only used for transport of glucose from outside of the cell membrane to inside of the cell membranes. So there is a two type of transporter important for facilitated transports. One more important thing in facilitated transport, it does not require energy from transport of molecule from one side to the another side. Then spatial transport include active transport mechanism. Active transport is characterized by movement of the chemical against the concentration gradient. The saturability at high concentrations, then selectivity of certain spatial structure features of the chemicals, competitive inhibitions by another transporters which inhibit the transport of one molecule to the another, and requirement of energy so that metabolic inhibition block the transport process. So substance actively transported across the cell membrane presumably form a complex with the membrane-bound macromolecules carrier on one side of the membrane, and the complex subsequently transfers to the another side of the membrane where substance is released. After the protein carrier return to its original surface to repeat the transport cycle. Here in these figures, we can see this is a sodium-potassium pump. Here we can see the three sodium molecules are attached to this protein carrier along with the ATP. And hydrolysis of this ATP leads to the phosphorylated pump protein and change the shape of the carrier protein. And on another side, it releases the sodium molecules outside of the cell membrane and enable that protein carrier for the sodium. So enable sodium molecule bind to that carrier protein and enter within the cellular structure. So this is nothing but the active transport mechanism. Spatial transport for the xenobiotics. In total, estimate that at least 5% of all human genes are transporter related, and it's important for the function of transport in the normal biological and toxicological outcome. Transporter mediated influx, it means uptake and efflux of the xenobiotic, can be divided into two categories, determined by whether they mediate the active or facilitate transport of the compounds, in which human membrane transporter are divided into the two major subfamily. First is SLC, solute carrier transporter, and another is ABC, ATP binding cassette transporter. In SLC transporter, transport mechanism facilitate transport and secondary active transport mechanism is there, whereas in ABC transport, primary active transport mechanism is there. SLC transport is bidirectional, whereas ABC transport is unidirectional. SLC transport mainly involve in influx transport, whereas ABC transport mainly involve in efflux transport from outside to the cytoplasm of the cell, whereas to the outside of the cell, that is efflux transport. For basic understanding of the nomenclature of the SLC, there is total 43 SLC gene families available or identified, which represent approximately 300 genes. Name of the individual SLC membrane have the following format. Take an example of SLC NXM. So SLC is the root name, that is solute carrier. SLC, solute carrier, and integrate the representation of the family, that is 43, that 1 to 43. X indicates a single letter ABC denoting the subfamily, and M is nothing but the isoform. Suppose take an example of SLC1A1. It means first isoform of subfamily A of SLC family 1. The type of transport mechanism having the facilitated transporter and second active transporter for the SLC transport. The major membrane of the human solute carrier transport family involved in xenobiotic dissociation. This is the name of transporter, is gene family, human protein, gene name, functions, and its toxicological impact mentioned in this slide. First is organic anion transporting polypeptide, which play an important role in transport of organic anion, cation, and neutral compounds. Another is organic cation transporter OCT, which play an important role in transport of organic cation. Then organic cation carnitine transporter is for the carnitine transportation. Then OAT, that is organic anion transporter, that is transport of anion. Another is peptide transporter, PEPT. This is important for transport of dipeptide and tripeptide and xenobiotics. Last is multi-drug and toxin extrusion transporter. In short, we can call it as a MATE. It is important for efflux of organic cation and localization in the kidney. Although they are largely regarded as the influx pump, solute can move bidirectionally. This protein appear to be especially important in the hepatic uptake of the xenobiotic. In human liver, the OATP 1B1, 1B3, and OATP 1A2 have been identified, whereas the major OATP in rat liver are OATP 1A1, OATP 1A4, and OATP 1B2. It means human transporter is slightly different than the animal transporter. So we have to carefully evaluate the toxicant mechanism of action based on this transporter available in the different species. This OCT family is important in both renal and hepatic uptake of the xenobiotic. Another xenobiotic transporter are the ATP binding cassette, ABC transporter. There is total 7 subfamily of the ATP binding cassette are identified. They are classified into subfamily from A to G with 49 genes. The total number of these genes identified in this family is 49 in the human. Many of these play a key role in homeostasis of numerous endogenous substances. For example, ABCA1 is major regulator of cholesterol in cells, mediating its efflux of the livers, and ABCB4 specially transport the phospholipid substrate. The typical structures of most ABC transporter consist of 2 types of structural domain, including hydrophobic membrane spanning domain and hydrophilic nucleotide domain. This is outside of the cell, this is cell membrane, this is inside. Here is MSD1 and here NBD1. And among these for most ABC transporter, binding and hydrolysis of ATP provided the energy required to the substrate to cross the cell membrane. These bold subfamily B, C, and G are indicated in the major role in the xenobiotic disposition or the transport of xenobiotic from one compartment to the another compartment. Another ABCB1, we can call it a multi-drug resistance protein, P-glycoprotein, also known as MDR, which have an important function of the efflux of the gut, brain, and placenta, and biliary excretion. Then bile salt export pump, BSEP, which play an important role in bile salt transportation. Multi-drug resistance associated protein 1, 2, 3, and 4, which play an important role in organic anion efflux. This is ABCC gene symbols. Then last is breast cancer resistance protein, BCRP, which are important role in organic anion efflux, many sulfate conjugate, and biliary excretion. Among these transporter, MRP2 and MRP3, particularly important in efflux of xenobiotic metabolites, especially those conjugated with the UDP glucuronic acids or glutathione. It play a critical role in glucuronidation in phase 2 metabolism. For example, glucuronide metabolite of acetaminophen is a substrate for both MRP2 and MRP3. Similarly, the BCRP, breast cancer resistance protein, is a member of ABCG family, was originally isolated from the breast cancer cell line, and it is expressed in variety of the normal tissue, for second example, liver, kidney, and intestine. It is also highly expressed in numerous stem cells, particularly the side populations of the human bone marrow and other organs such as a placenta, mammary gland, where it is provide the protection from the xenobiotics. ATP binding cassette transporters are widely expressed in the human tissue such as lungs, blood-brain barrier, brain, liver, pancreas, small intestine, gallbladder, testis, prostate, kidney, supraannular, placenta, even in the lymphocytes. So there is a vast network of ABC drug transporter for this transport mechanism of absorption and distribution. Additional transport process. Other form of specialized transports have been proposed, but their overall importance is not well established as that active transport and the facilitate diffusions. But the two processes, phagocytosis and pinocytosis, are proposed mechanism for the cell membrane processing. Pinocytosis is important to take the fluid or a solute material from one side of the cell membrane to the other side. And phagocytosis is important to take the larger substance or the larger particle molecule, and sometimes the microorganisms are also engulfed by the macrophage or the cell. Mainly in the inhalation study, when there is an exposure of the dust particle which are inert in nature, which is available in the alveoli, are removed out from the alveolar parenchyma through this phagocytosis mechanism. The macrophage engulfs that inert material and remove it from the lung parenchyma. The mechanism of absorption summary. Here, when lipophilic compounds are transferred through the transcellular mechanism, because of the lipid bilayer structures of the cell, it is easily transferred. When there is a hydrophilic compound, it transfers through the paracellular level, but the molecular size of that water molecule containing molecule is small. Another is carrier-mediated transport mechanism, in which different transporter play a critical role, or the carrier protein play a critical role from transport of toxicant from one side to the another side. Last is a specialized transport mechanism for absorption. It includes phagocytosis and pinocytosis. Routes of drug administration. Experimentalists and medicinal professionals divide the route of administration into two parts. First is enteral and another is parenteral. Enteral route of administration include oral, sublingual, and rectal, where the parenteral administration involve other route of administration other than the enteral. Parenteral, other than the enteral, which include inhalations, intravenous, intramuscular, subcutaneous, intraarterial, and so many. Here, the inhalations and transdermal or sometimes topical administration of the trace item produce the localized effect, and the toxicant are not reach into the systemic circulation. Then, factor governing the choice of route selection for drug administration, which include the physical and chemical property of the drugs, whether the drug may be solid, liquid, gas, and it's lipid soluble or water soluble, its stability, pH, and irritation of the compounds are important for selection of dose. Site of desired action, rate and extent of absorption from various routes, effect of digestive juice and first pass effect on the toxicant or the molecules, rapidity of desired response, whether we require the emergency response or delay response or the chronic response, accuracy of doses, and conditions of the patients, whether the patients can able to take that medicines through the oral route or due to some vomition or unconscious conditions, we have to select the route of administration. Absorption of toxicant by gastrointestinal tract. The GI tract is one of the most important sites where the toxicants are absorbed and produce its effects. Absorption of toxicants can take place along with the entire GI tract, even in the mouth or in the rectum also. Therefore, all the majority of the drugs are given orally. Drugs such as the nitroglycerins are administered sublingually, whereas the other administration is a rectal suppository also. The particle size is inversely related to the absorption, such as the absorption increase with decrease in the particle size, and this explains when the metallic mercury is relatively non-toxic when ingested through the oral route, whereas the powder of arsenic was bound to be significantly more toxic than its coarse granular form. Another parameter is lipid solubility. When as the increased lipid solubility increase the absorption of chemical, and extreme lipid soluble chemicals is unlike to dissolve in the aqueous fluid within the GI tract, which limit the absorption from the GIT. There are numerous additional factors such as pH, presence of food, digestive enzyme, bile acid, bacterial microflora in the GI tract, along with the motility and permeability of the GI tract also influence the absorption rate of toxicants. Further, before a chemical enter into the systemic circulation, it can be biotransferred by the cells in the GI tract or extracted by the livers and excreted into bile with or without prior biotransformation. This phenomena of removal of the chemical before entrance into the systemic circulation is referred to as a pre-systemic elimination or the first pass effect. absorption by simple diffusion is also proportional to the surface area. When there is an increase the surface area, the chances of absorption is more. In the small intestines, particularly in the duodenum, has a very large surface area because of the villi and microvilli. They increase the surface area approximately 600 folds than the other lumen. The GI absorption is often higher in the dog compared to the other species because paracellular absorption is to occur to the greater extent in the dog as compared to the another species. Numerous xenobiotic transporters are expressed in the GI tract, where they functions to increase or decrease the absorption of xenobiotic or toxicants. Yes, this is a lumen and this is a blood vessel. This is a mucosal epithelial part of the. This is a lumen, this is a blood vessel, and this is a mucosal epithelial part of the GI tree, where the different influx transporter, efflux transporter is available. Among them, MRP2 and MRP3 protein expression were higher in colon than in the small intestine, whereas MDR1 expression increased from the duodenum to colon, whereas MRP2 and most of the uptake transporter are expressed most highly in the duodenum and decrease in the terminal ileum of the colon, whereas the BCRP is found throughout the small intestine and the colon. The OATP inhibitor transporter in the gut has been reported for the common juice such as the apple juice, grapefruit juice, and orange juice, which inhibit the absorption of the certain compounds. This transporter can also function to limit the oral absorption of the drugs. Suppose take an example of immunosuppressive drug, cyclosporine, and the chemotherapeutic anti-cancer drug paclitaxel, colchicine, vincristine are not readily absorbed from the GIT because they are good substrate of MDR1. Another example is infants are more susceptible to methemoglobinemia because higher pH of neonatal GIT is permissive for the growth of the bacteria that convert the nitrate to nitrite and develop the methemoglobinemia. Furthermore, some chemicals used as a laxative reduce the absorption of xenobiotic by increase the intestinal motility, whereas the agent used antidiarrheal may increase the absorption by slowing the intestinal motility. The number of toxicants actively absorbed by GI tract is low, and most enter body. Most of the toxicants enter it through the GI tract through the simple diffusion mechanism. A weak organic acid, such as a benzoic acid, is present mainly in the non-ion lipid-soluble form in the stomach and predominantly ionized form in the intestines. Therefore, weak organic acids are absorbed more readily from the stomach than from the intestine. In contrast, suppose if there is an organic base are likely to be ionized and not lipid soluble in the stomach, but are more likely to be in a non-ionized form in the intestine. So its absorption is more in intestine. And approximately 1,000 bacterial species have been characterized in the GIT. The toxicants may be hydrolyzed by the stomach acid and biotransferred by the enzyme in the GIT and modified by the resident microflora which are available in the GIT, and parent compound are converted into the different metabolite part. Suppose take an example, snake venom, which are proteinous moiety, are much less toxic by the oral route relative to the intravenous exposure. because they are degraded by the digestive enzymes and the microflora of the GI tract. In general, certain chemicals such as a chelator, we can call it the EDTA, increase the absorption of toxicant by increase the intestinal permeability. And increased permeability is thought to result from the chelation of the calcium, chelation of calcium by EDTA that is involved in the formation and the maintenance of the tight intracellular junctions. Thus, that binding of the calcium reduce the integrity of the cell junctions and allow more toxicant to pass through the paracellular absorption. Thus, it is important not to administer chelator orally when excess metal is still available with the GI tract. So, with the help of EDTA, chelator effect increase the paracellular transportation. In general, mice are considerable to be an excellent model for studying the changes in the gut microbial diversity. Rats are suggested for the better reflect the human gut composition, whereas NHP and non-human primate chimpanzee have a similar gut microbial compositions are found in the human. For our better understanding of percent of dose absorption and excretion of radioactivity in rat, dog, and human after nadolol doses. Here, rat 20 mg per kg are given through intraperitoneal and oral. Similarly, dog 25 mg per kg dose given to intraperitoneal oral and human 2 mg per kg intraperitoneal oral. Here, intraperitoneal route of administration we can consider as a 100% bioavailability. Along with by comparing the intraperitoneal and oral, how much absorption occurs in the different species. Here, rat, the persons of dose absorbs is only 18%, whereas in the dog is nearer about the 100%, whereas in human it is 34%. What it indicates, compound is remain same because of some biological changes in that species. The route of absorption is same, but percent of dose absorbs is different. So rat is less absorbed dose of the nadolol than human, and finally dog absorbs more dose, more drug or toxicants as compared to the other one. pH of the gastrointestinal count of various species is different. In the stomach, the rabbit have a 1.9 and rest of have a 2 to 3 pH is there. Based on the pH variations, the absorption of toxicant is also different. Absorption of toxicant by lung. Toxic response to chemical can occur from absorption following the inhalation exposure. Relevant examples include carbon dioxide poisoning, silicosis, asbestosis, and important occupational disease. And this toxicity results from the absorption or depositions of the air position in the lungs. Major group of toxicants that are absorbed by the lungs are gases, carbon monoxide, nitrogen dioxide, sulfur dioxide. It may be in vapor or dust form. Sometimes volatile liquids, benzene, carbon tetrachloride, and particle aerosols also affect the lung. This is a diagram of the respiratory system. This is a nasal part, larynx, trachea, bronchi, bronchioles, and finally, this is a alveolar structure which is highly vascular. So chances of absorption of particle from the alveoli is more as compared to the other part of the respiratory system. Most organic solvent evaporate and produce the vapor. The absorption of inhaled gases take place mainly in the lung. However, When inhaled gases first pass through the nose, it filters with the highly scroll structures. We can call it as a nasoterminate, maxilloterminate, and ethmoid terminate with the different epithelial cell layer, which restrict the toxicants enter into the lower respiratory system. Another mechanism of the mucosa of the nose, which are having the mucous layer, the fluid mucus layer, where inhibit the transport of toxicants and act as a scrubber for the water-soluble and highly reactive gases. Partially, it is protecting the lung from potential injurious insult. Although these actions may serve to reduce the systemic exposure to protect the lungs, but there is an increased risk of adverse effect to that nasoterminate, maxilloterminate, or ethmoterminate based on the different toxicant natures. Here, formaldehyde and vinyl acetate, which are having highly vapor pressures, causing the tumor in the different nasal terminate, which are already experimented in the rat. When equilibrium is reached, the rate of transport of gas molecule from alveolar space to blood equal to the rate of removal from the blood from alveolar space. The absorption of gases and vapor by inhalation is determined by the partitions of the common between blood and gas phase, along with its solubility and tissue reactivity. In contrast, the important characteristics that affect the absorption after the exposure of aerosol are the particle size of the aerosol and water solubility of any chemical present in the aerosol form. The site of deposition of aerosol and particular matter depend largely on the size of the particle. The fine particles are deposited mainly in the tracheobronchial region of the lung, from which they are cleared by the retrograde movement of the mucus layer in the ciliated portions of the respiratory tract. It is also known as mucociliary escalator. Coughing and sneezing greatly increase the movement of mucus and particular matter towards the mouth. The external small particle may absorb into the blood or clear through the lymphatic after being scavenged by the alveolar microfacies. The blood to gas partition coefficient, chloroform, have a blood to gas partition is 30, is easy to absorb and hard to eliminate, whereas ethylene and ethane, it is hard to absorb and easy to eliminate. Particle ranging from 5 micron or larger, described as a coarse particle, usually are deposited in the nasopharyngeal region. Here, the parameter influence the particle depositions. First is impaction. When the airflow direction change, the inertial force of any particle try to remain in its normal direction. So high flow proportional to the angle change and velocity important for the inertial impaction of the particle. Another is sedimentation. Particles settle under the influence of the gravity, and it is important for the large particle. Last is diffusion. Bombarding of aerosol result in random particle movement, low flow, and it mainly available in the alveoli sector, where the diffusion occurs and toxicants are passed from the alveolar part to the circulation part. And the particle with aerodynamic diameter greater than 5 micron are deposited by the impaction primarily in the nasopharyngeal region. These regions have a highest air velocity and turbulence, whereas the particle size of 1 to 5 micron diameter are deposited in the by the sedimentation technique along with the tracheobronchial tree. And the smallest particle which are near about 1 micron or less than 1 micron, reaches the small intrapulmonary airway and deposited by the diffusion mechanism. Absorption through the skin. Skin is the largest body organ and provide a relatively good barrier for separating the organism from their environment. Overall, human skin comes into contact with the many toxicants, but exposure is usually limited by its relatively impermeable nature. The stratum corneum is unique, anatomical, and represented as the single most important barrier to prevent the fluid loss from the body, while it also serves as a major barrier to prevent the absorption of xenobiotic into the body. Yes, the skin comprises of two major layers, epidermis and then dermis. The epidermis is outermost layer and contain keratinocytes that are metabolically competent and able to divide. By proliferation of keratinocytes into the stratum germinatum of stratum basalis displace mature keratinocyte layer upward until they reach to the outermost layer that is called as stratum corneum. The stratum corneum is important. The stratum corneum contains densely packed keratinized cells that have lost that nuclei and are biologically inactive. The stratum corneum is replaced approximately every 3 to 4 weeks in adult human. And this complex process involves the dehydration and polymerization of intracellular matrix and forming the keratin-filled dry cell keratin layers. So although the major anatomical features of the keratin prevent the entry of the toxicants. So all toxicants move across the stratum corneum by passive diffusion. In general, lipophilic compounds are absorbed more readily across the stratum corneum, whereas the penetration of the hydrophilic compound is more limited. However, some chemical can be absorbed by the skin in sufficient quantity to produce a systemic effect. For example, there are several insecticides for which fatal exposure have occurred in the agriculture worker after absorption through the insect skin. In addition, there are numerous chemicals that increase the tumor development. In other organ after dermal applications, it reaches to the systemic circulations. The stratum corneum is more thicker in the human than in the most laboratory animal, making human skin typically less permeable than the animal skins. So with the help of animal experiment, whether it is more sensitive as compared to the human skin. There are several factors that can influence the absorption of toxicants through the skin, which include integrity of the stratum corneum. When the caustic agents such as the acid or alkali that damage the stratum corneum, ultimately it results in increase the permeability. Another factor is the hydration state of the stratum corneum. This amount of water increase the permeability of stratum corneum approximately tenfold over the permeability that exists when it completely dry. So the cream and other compounds have a more water content when it applied to the skin regions for better absorption. Temperature. Similarly, an increased temperature will increase the dermal penetration by the increased blood flow. And solvent as a carrier. Solvent used to dissolve the compound can also influence the dermal penetration. Suppose an example of dimethyl sulfoxide, DMSO, can facilitate the penetration of toxicant through the skin by increase the permeability of the stratum corneum. And last is the molecular size. With respect to the molecular size, it is generally recognized that compound above 400 Dalton exhibit the poor dermal penetrations. In contrast to the skins of the scrotum, is characterized by the thin stratum corneum and highly diffusivity. Consequently, comparative difference in absorption of malathion across the different skin regions and toxicants are likely to readily cross the scrotal skin, whereas the absorption of across the forehead skin is less extensive and penetration across the palm is lowest because of thickness of the stratum corneum and lack of dermal appendages. This here we can see the scrotum have a more absorption as compared to the palm because of the difference in characteristic of the skin structures. LD50 of injected DDT is approximately equal in the insect and the mammal. But DDT is much less toxic to the mammal than to the insect when it applied on the skin. Why? These appear to be due to the fact that DDT is poorly absorbed through the skin of the mammal, but it passes rapidly through the chitinous exoskeleton of the insect. Furthermore, insects have a much greater body surface area related to weight than the mammals. So it gives the more toxicity to the insect, and mammal does not produce any toxic effect. Special route of administration. Most common special route are intravenous, intraperitoneal, subcutaneous, and intramuscular. The intravenous routes introduce the toxicant directly into the bloodstream. It is bypass the first pass effect, eliminate the process of absorption. Intraperitoneal injections result in rapid absorption of xenobiotic because it reaches the peritoneal and mesenteric blood supply and relatively large surface area of the peritoneal cavity. Subcutaneous and intramuscular injection usually result in slower absorption rate than the intravenous, but toxicant enter in directly into the general circulations. Suppose epinephrine causes the vasoconstriction and will decrease the rate of absorption if it is co-injected intramuscular with the toxicant. The formulation of xenobiotic may also affect the rate of absorption, as the toxicants are typically absorbed for more slowly from suspension than from the solution. If the toxicant is injected intraperitoneally, most of the chemical enter in the liver via portal circulation before reaching to the final systemic circulations. Here, the different factors affecting the absorption. First, when we administer the drug through the oral route, the propal breakdown of the tablets or drug molecules through the disintegration and dissolutions of the drug through the different media is important. Then and then proper absorption is possible. The formulations also play a critical role. When more binder is present in the formulations, so it is very difficult to disintegrate in the stomach and absorption is decreased. Lipid solubility, more soluble, more permeable. The pH and ionization, presence of other drugs by transporter inhibition mechanisms, gastrointestinal motility, more motility, the food particles are move faster through the peristaltic movement. Then food decrease the absorption of the toxicants. Certain disease conditions of the vital organs such as the liver, kidney, brain, and heart also impair the absorption mechanism. Vascularity is directly proportional to the blood flow to that specific organs. Metabolism to the livers. It creates the polar compounds and excreted from the body. If it is impaired, then there is a change in the absorption. More surface area, more chances of absorption, lesser particle size, increase the absorption as compared to the bigger particle size. With this, we switch over to the distribution.